me great pleasure to introduce our first speaker, Professor Sir Muir Gray, Executive Director of the Oxford Value and Stewardship Programme, Director of the Optimal Ageing Programme, and Founding Director of the Critical Appraisal Skills Programme, plus too many other achievements to mention in the time available. Sir Muir.
Thank you. Next, please. And I've got my stopwatch running. So, next slide, please. So every society on Earth faces need and demand increasing faster than resources. I've been 50 years in healthcare and it's been fantastic. I've had about 15 reorganisations, most of which have made no difference at all. But I've seen fantastic technological developments, transplantation, stents, chemotherapy, and also decision-making paradigm shifts, creation of the Cochrane collaboration, then we set up a Centre for Evidence-Based Medicine, and then in the last 20 years, the Quality Initiative, including efficiency. But we've overlooked three huge problems. The first of these is unwanted variation, first described by Jack Wernberg, who died 2 months ago, in the fantastic atlas of variation from Dartmouth. And here's the atlas from England. This was back 2014. But I don't think it's changed much since then. On the left is variation in activity. On the right, variation in spend. Threefold variation in spend on musculoskeletal. Next, please. Now, unwanted variation reveals two other problems. Next, please. Thank you. The first of these is a fantastic diagram based on Obedium. And I just ask you all to think, where have we gone beyond the point of optimality? And I would do this in a town hall as well as a health centre or hospital. Next, please. The other problem revealed is inequity. Now, more of the same is not the answer. Next, please. We need a new paradigm, and that new paradigm is value-based healthcare. And here's the definition of value that was developed by the EU and the G20 with the NHS, actually, before Brexit, playing a key role. Personal value. Are we treating people's problems or treating people's diagnosis? And that applies particularly to elective surgery. Allocative value. There's probably still a twofold variation in spend on, say, respiratory or musculoskeletal from one population to another. And I think we've stopped publishing the variation in spend. So huge variation in spend, because we've never actually allocated anything. It's 70 years of drift to determine spend. Then technical value, which is much more than efficiency, and then social value, anchor institutions, for example. Next, please. So just to emphasize the point that productivity is part of efficiency, but technical value is much broader because it includes the people who aren't being referred to the hospital. So instead of thinking only about the productivity of spinal surgery and day case surgery, we need to think about back pain in the population. And could the resources be used to prevent back pain as well as to treat surgery? Next, please. Now, I welcome this report on productivity. And as you can see, there's a paragraph on value. I would have produced a report on value with a subsection on productivity, but that's not my call. So next, please. So what we need to think of is a new paradigm that focuses on value and, one back, please, value and waste. Next, please. Now, waste is much more than inefficiency, and it's to do with the overuse of effective interventions. And John Decker said, there's nothing more stupid than doing something efficiently, more efficiently, which should not be done at all. On the right-hand side, you can see lab testing in Oxford, GP lab testing, just up to 2015, and it's continuing. A friend had a blood sample taken for one variable, and the lab reported 30 variables. And I saw, to my surprise, that liver screening, kidney screening, and thyroid screening have just been added to the lab tests. The paper Good for You is a very important paper. 10% of other drugs prescribed do no good, and 20% of hospital admissions of older people have drug side effects. And I speak as someone who's taking 7 pills a day, so I'm not anti-drug. Next, please. So when we look ahead, we need to think in a different way. And here's the definition of waste. Not just inefficiency, but for example, doing operations that don't actually tackle the person's problem, or using resources that would give more value if switched to another intervention for this population or to another subgroup of the population altogether. Next, please. So waste is the key issue. And remember, resources are not just money, it's time, money, and carbon. And carbon motivates clinicians much more than money. So here are the 5 steps to create value-based healthcare. Develop a population approach, develop a system for each subgroup, people with COPD, for example, deliver through networks, remember personal value, and create the culture of stewardship. The clinicians need to feel responsible for the fact that we want an NHS to exist in 10 years' time, and they don't waste resources. Next, please. The key issue here for this audience, I think, is the shift from 2D healthcare to the next slide, please. 3D healthcare. And I'm aware how many hospitals there are in the audience. To become obsessed with the population, with every department having a map on its wall, looking at having a budget that is for the whole population, and monitoring for inequity, seeing where the referrals are coming from. Next, please. So to finish, here's the sort of questions we're asking ICSs, and you could take out any, I picked on poor old Kent here, I think, but you could take any population with this. And we're working with Strasys because I don't deal with the sort of day-to-day, the short-term pressures, but you guys have got to deal with. We're trying to find a radical solution. So Strasys and the OVSP are going to work together to change continuous quality improvement to continuous value and quality improvement. So 6 minutes, 54 seconds. That is the future. Value-based healthcare and population healthcare.
Thank you very much, Muir. Wonderfully succinct there. No, you very helpfully set out the 4 different types of waste. But aside from low productivity and inefficiency, what do you see as the main causes of waste in the system?
It's partly defensive medicine, but mostly just sort of over-enthusiastic interventions. If you look at the increase in the number of imaging, of blood tests, but also I think the public needs to become much better aware of the fact that all healthcare does harm. And they need to understand that not all elective surgery will go well, even in the best of hands. So it's this, what David Eddy called the relentless increase in the volume and intensity of clinical practice. And I believe the only way to resolve this is to gather the resources with working with people I call directors of finance and value, and saying to people, well, ladies and gentlemen, in Derbyshire or in Dickensshire, you're spending £75 million on lung disease. Do you think you've really got it right? Or is there overdiagnosis of asthma in children? Or maybe you should switch some money from triple drug therapy to rehabilitation and smoking cessation. So I think we have to go for developing the culture of stewardship. And if I'd had another period of time, and I'd spoken about the wonderful Eleanor Ostrom, who created the concept of stewardship. People managing common finite resources, if they're not given responsibility for managing them, the tragedy of the commons will occur.